Good morning, everybody. I'm Dr. Srimati, and I thank Janitri for having given me this opportunity to do this case series. Right, today I'm going to be discussing about a 30-year-old primate who was a late booker with a BMI of 33. She was induced at 40 weeks because the lack of volume was reduced. She made reasonable progress and she needed an instrumental delivery because of decelerations on the CTG. We applied forceps, it was an easy application, and the baby came down with two pulls. Right. So should we be prepared for anything in this patient? Yes, definitely. Shoulder dystocia. Why? Because she had a BMI of more than 30. She had her labor induced. She had oxytocin augmentation, and she also had an assisted vaginal delivery. Obviously, we would expect her to have a long first stage or second stage, which didn't happen incidentally in her. So all of these risk factors help us be sort of cautious for a possibility of shoulder dystocia. Many a time it happens when we are not prepared, and as we know, more than half of the times it happens with normal sized babies. So it is important that we are always vigilant for a possibility of shoulder dystocia. So we were vigilant, obviously, and we did have help around, and she'd already had an episiotomy. So what do we do immediately? We took her legs off the stirrups and put her in McRoberts position, which is basically having the legs hyperextended and abducted. And we also started giving suprapubic pressure. So this suprapubic pressure has to be given from the side where the back is. So now it's important that we ask her to not push, and we also do restrain from giving fundal pressure. And also traction should not be anything more than gentle. These are very, very important in order to avoid any neonatal injuries. So the McRoberts position, the whole idea is it increases the anterior-posterior dimension of the pelvis and so helps in freeing the shoulders. Suprapubic pressure helps us move the shoulders to the oblique dimension and also helps in adducting the shoulders so that reducing the bisacrobial dimension. And luckily for us, the baby was born with these maneuvers. If not, we were prepared for doing the entire maneuvers, which I will come to later. Right, so what did we do after delivery? We immediately clamped the cord and we ensured that the cord was double clamped because it is important that we do cord gases because we want to ensure that the baby was not hypoxic. It was a very important medical legal defense for us. And while the baby was attended to by the neonatal team, we also made sure that the mother did not end up having a postpartum hemorrhage or she did not have any vaginal tears. It is important that we have a skilled neonatal team in attendance for any difficult deliveries and especially for instrumental deliveries so that the babies can be resuscitated appropriately. So once the delivery is complete, it is important that we use a proforma to document. And in the documentation, it is important that we mention the time of delivery of the head and time of delivery of the baby. It is also important to mention which was the anterior shoulder because if we do have the posterior shoulder being affected by Erb's palsy, then it is possibly because of in utero positioning. It is important to debrief the couple and also the healthcare professionals involved and follow it up with an incident form and ensure that we have a sort of a debriefing of the team to discuss about what went well, what could have been done better, so that we could prevent complications in future incidents. Now this is the protocol which is being given by RCOG for management of shoulder dystocia. It is important that we have that in display in our labor room so that it serves as a ready reckoner. So what do we do? It's a helper maneuver. You call for help, you evaluate for episiotomy, you put the legs in McRoberts, you also give suprapubic pressure. Okay, and as I said before, discourage pushing and don't give fundal. Now you then think about the enter maneuvers. Either you can do the removal of the posterior arm or you can do the internal rotation maneuvers. So choice is dependent upon the experience of the attending obstetrician. Obviously, if these do not work, then we might have to go and start again. While if it's possible, especially in remote areas, you can think about doing an all fours position, that is a knee chest position, and this is supposed to be beneficial in terms of freeing the anterior shoulder and in terms of facilitating the delivery. So in terms of the internal rotation maneuvers, the whole idea is to rotate the shoulders into the oblique dimension, and as we did it in the suprapubic pressure, so that we can facilitate the delivery easily. All throughout, it is important to bear in mind that we give only gentle traction because forced traction can also cause Erb's palsy. Okay, it is important that we fill an incident form, debrief the couple, especially if there has been any residual nerve damage or fractures, because this can be a medical legal problem. It is important to explain the prognosis and the follow-up needed for these babies, so that the care given to these babies are appropriate. So I thank Janitri for having given me this opportunity, and I hope I've been able to give some knowledge about shoulder dystocia. So it is important to remember to be vigilant and ensure that we have skill stills and also have a structured protocol in place so that we can manage when this obstetric emergency happens, because it is a nightmare to the obstetrician, but it is important that we are prepared to manage this. Thank you.